You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about cardiopulmonary exercise testing, or CPET. According to the 2024 Heart Transplant Candidate Guidelines, in ambulatory adult heart failure patients referred for transplant evaluation, CPET should be routinely be performed to quantify exertional intolerance, form heart failure prognosis, and guide transplant listing. That is a Class 1 recommendation. So how does this work? In a CPET test, the patient exercises on a treadmill or a stationary bicycle, starting at a low intensity with gradual increases in workload at regular intervals, usually every 1 to 3 minutes. There is continuous monitoring of respiratory gases, including oxygen consumption and carbon dioxide production, ventilation rate for determining breathing efficiency, ECG, heart rate, blood pressure, oxygen saturation, and patient symptoms including perceived exertion and breathlessness. The test continues until the patient reaches volitional fatigue, which is the point where the patient can no longer go on due to exhaustion, unless any concerning symptoms appear before that point or any malignant arrhythmias appear before that point that necessitate premature termination of the test. This test works because unlike other organs, the myocardium extracts oxygen from blood nearly maximally at baseline, so there's not much leeway. Even at rest, O2 sat in coronary veins, measured at the coronary sinus, is quite low at less than 40%. The key concept here is peak oxygen consumption, or VO2 max. Peak oxygen uptake is the value at which oxygen uptake plateaus despite a continued increase in the intensity of exercise. In other words, it is the maximum amount of oxygen that the body can utilize during exercise. A peak oxygen consumption of more than 20 mL per kg per min reflects normal or mild functional impairment. A peak oxygen consumption of less than 14 mL per kg per min indicates severe functional impairment. In women, compared to men, a peak VO2 of less than 12 mL per kg per min can be used as a threshold that indicates severe functional impairment due to generally lower aerobic capacity compared to men. When you do CPET testing on a CHF patient pre-transplant, a VO2 max less than 14 mL per kg per min or less than 50% predicted is associated with worse prognosis on heart failure. A reduced VO2 max is one indication for the evaluation for advanced heart failure therapies such as transplant or mechanical circulatory support. Conversely, patients who achieve a VO2 max of above 14 mL per kg per min have a mortality rate similar to patients who have undergone transplantation and would be less likely to benefit from transplant. Peak oxygen consumption and anaerobic threshold are superior to ejection fraction and functional class in predicting heart failure outcomes. Patients with severely depressed EF can have a wide range of exercise capacities, with some being near normal, so exercise testing is important to quantify true functional limitation in heart failure. Patients with VO2 max of less than 14 mL per kg per min need to exert their maximal exercise capacity in order to be performing activities such as walking, playing golf, or raking leaves. Such patients would be unable to complete stage 1 on a standard Bruce protocol. The next important concept is the anaerobic threshold, or AT. The anaerobic threshold during exercise is the VO2 at which lactate begins to accumulate in the blood and carbon dioxide production starts to rise, resulting in an increase in the VCO2 to VO2 ratio. A low anaerobic threshold, less than 11 mL per kg per min, is associated with poor prognosis and may also support heart transplant listing. In patients who are unable to reach maximal exercise due to physical limitations and thus not be able to provide a VO2 max for the test, the anaerobic threshold can still provide valuable information about functional capacity. Both the peak oxygen consumption and anaerobic threshold are reproducible when measured days or weeks apart. The next important concept is the ventilatory equivalent slope, or VE over VCO2. Upon reaching the anaerobic threshold, when carbon dioxide production starts to rise with an increase in the VCO2 to VO2 slope, the minute ventilation will also rise disproportionately to oxygen consumption. The VE to VCO2 slope is the ventilatory equivalent. It is the ratio of minute ventilation, which is VE, to the carbon dioxide production, which is VCO2, and it reflects ventilatory efficiency. VE to VCO2 slope more than 35 indicates poor prognosis in heart failure, even if peak VO2 is higher than 14 mL per kg per min, because that indicates poor ventilatory efficiency. If peak VO2 does not provide a clear indication, the VE to VCO2 slope can serve as a complementary parameter in deciding the urgency of transplant listing. Okay, it's great to understand what each of these concepts are, but when you're actually running the CPET test and reading the CPET output, how do you know what you're looking at? So I want you to imagine a plot with time on the x-axis and the y-axis displaying a scale for VO2, which is oxygen consumption, and a scale for VCO2, which is carbon dioxide production. You have two sets of dots. You have a set of dots for VO2 and a set of dots for VCO2 over the course of exercise. At low intensities, the VO2 and VCO2 are going to increase together in a linear manner, maintaining aerobic metabolism. As exercise intensity increases, the VO2 continues to increase linearly while the VCO2 starts to rise more steeply, more sharply due to the increase in CO2 production from the buffering of lactate, indicating that anaerobic metabolism is kicking in. The point of intersection or crossover is the point where the slope of the VCO2 starts to increase more rapidly than VO2, i.e. it departs from traveling in parallel, and that marks the anaerobic threshold. At this anaerobic threshold, the body can no longer meet its energy demands solely by aerobic metabolism, and it begins relying on anaerobic metabolism, which is a process that produces lactate and increases CO2 output. Another very common variation of this plot that you need to know about is when they display the y-axis as the VE to VO2 ratio and a VE to VCO2 ratio. That is, they put the VO2 and VCO2 into the denominator. So instead of a constantly upward rising pair of lines that departs from parallel rising to the VCO2 one rising more steeply than the other after anaerobic threshold is surpassed, you instead get a mildly downsloping set of lines in parallel until you hit the anaerobic threshold. After that point, the lines will diverge. Minute ventilation, which is in the numerator, increases disproportionately to VO2, but minute ventilation increases proportionally to VCO2. Therefore, the VE to VO2 curve will rise significantly, whereas the VE to VCO2 curve will remain flat or mildly rise. That's an important concept to understand so you can interpret these graphs on the CPET test. Then the other important concept is the respiratory exchange ratio, RER, which is the ratio of the VCO2 to VO2. This VCO2 to VO2 ratio is an indicator of exercise effort. A VCO2 to VO2 ratio less than 1 means a submaximal cardiovascular effort. A higher VCO2 to VO2 more than 1.1 during CPET indicates that maximal effort has been achieved, ensuring the reliability of the peak VO2 and other measures. If this respiratory exchange ratio is low, the results may underestimate the patient's exercise capacity. What does this look like? Imagine a plot with time on the x-axis and respiratory exchange ratio on the y-axis, or the VCO2 over VO2 ratio on the y-axis. And then the scatter plot data is just exactly that, the respiratory exchange ratio. You're going to have a scattered but converging set of dots in a horizontal line until you reach the time that you hit the anaerobic threshold, after which the RER will abruptly shift from a horizontal line to an upsloping line because the respiratory exchange ratio is VCO2 over VO2 and carbon dioxide production starts to rise disproportionately after reaching the anaerobic threshold. During exercise, the cardiac output of a normal heart can increase 6-fold and the body's oxygen consumption can increase 18-fold. The exercise limitation in patients with CHF is mainly due to alterations in skeletal muscle metabolism with contributions from abnormalities in autonomic and ventilatory responsiveness, increased lactate production, and inability to augment cardiac output. That's all I have for you for cardiopulmonary exercise testing.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.